All right, welcome back, everybody. Thank you so much for being here, each and every one of you. Our mental health LAPD feels like, hey. I'm Christopher Sears. I'm director of the Sax Institute. I just want to thank each and every one of you for coming here. I know it's, let's all get together and talk about COVID and mental health. So I'm glad that you're here. I want to thank Pam so much. She is absolutely co-organizer when Elyn and I decided to do this program, and the focus and topic came from Elyn. We were kind of like, okay, we're going to do COVID and mental health, mental illness. What do we do now? And we're so grateful for Pam to be here, and for all the speakers that came from around the country. We're just thrilled. So now it's therapy in the time of COVID. So here we go.
Thank you, Chris. All right. Well, I get to share the stage with Elyn Sachs, so that's very exciting and daunting. But I'm going to introduce our three panelists, and then we will kick it off. So let's see. I'll start with you, Lin. Lin Hogan is a doctor of clinical psychology and an adult psychotherapist at the Weems Community Mental Health Center in Mississippi. Next to him, Tristan Scremin is a peer manager for Painted Brain. And to my left, Huzaifa Ashraf is a clinical assistant professor of psychiatry at the Keck School of Medicine here at USC. Elyn, I don't know if you want to start, but I thought maybe we could just have each of you three kind of just describe how you interact with mental health and what you do, because you each have very different roles in the mental health sphere, and I think that'll help set the stage for the discussion. You want to start, Lin?
Me? Yeah. Sure. Well, good afternoon, everybody, and I just want to say I'm really grateful to be a part of this program. I've actually learned so much from the previous presenters and the panelists, and so it's really, what an awesome experience for a Southern guy from Mississippi to come out here to California, this beautiful campus. And the highlight of my career is Dr. Sachs said I can call her Elyn. So I'm good. I can drop the mic. I'm Dr. Lin Hogan. I'm a doctor of clinical psychology and adult psychotherapist at Weems Community Mental Health Center in Meridian, Mississippi. If you've never heard of Meridian, it's in east central Mississippi. We cover 9 counties. We have about 10,000 patients on an outpatient basis at any one time. I'm a master's addiction counselor, amongst other things. My mother calls me dangerously overeducated. And so I can tell you this, this COVID situation has turned our mental health picture in the state of Mississippi on its ear. We do not have enough providers. We have lost providers. Turin had talked about nurses and things like that. It's true that people are leaving the industry. I've been busier in the last 8 to 10 months as an outpatient adult psychotherapist than I've been in the last 25 years of doing this. Can't keep up.
Wow.
It's unbelievable. But anyway, I have a lot to say. I don't know what direction you want me to go in, but I definitely resonate with a lot of things I've heard from you guys. It's outstanding.
Yeah, no, that's a great introduction, and let's have Tristan and Huzaifa introduce themselves as well and what they do, and then we'll circle back and talk about how, more granular level, how, COVID has affected mental health and mental health therapy for people who are already suffering.
My name is Tristan. I'm a peer support specialist. I'm also trained. I have a JD and an MFA also, so I appreciate that dangerously overeducated comment. A couple of people said that about me too. And, I work for Painted Brain, which is a peer-run nonprofit. So we work with peers all over LA County. We have a community center. And we've done a lot of work around COVID too. We won this Cal Help FEMA grant, and even before that, we did a ton of work with organizations and all throughout LA County. So I don't know if there's something more you want me to add here, or
Well, I'm just sort of interested in how the peer support program works. Like, what are you?
right?
What
Okay,
are
a lot
you
of people
doing?
don't know that. So I'm trained as a peer, which means I'm a person with schizophrenia. I have lived experience of dealing with, firsthand experience of mental illness. Painted Brain is also a peer-run organization, so everyone, almost, I wouldn't say absolutely everyone, but 99% of the people at Painted Brain either have a serious mental illness, are a family member, or are dealing with some kind of serious trauma in their life. So we are people with the experience, and we provide peer support. So we're not therapists, we don't provide psychotherapy or anything like that. We believe in the voluntary, like the mutual type of relationships that peers form with each other, and we support each other in that way. We have a community center, and we run online groups. We've moved a lot of our stuff online because of COVID, and other factors of transportation in LA. So the peer work has been really central to our response to COVID and what we could do within the peer realm. So that's really important to us. We are very diverse. I'm an immigrant. I came here from Latin America, born in Argentina, immigrated here in the 1970s when I was a little kid, along with my parents and my grandparents. Also, Painted Brain does have a lot of different language speakers, including Mandarin and Japanese and several other languages. I can't remember them all, but there's probably like 5 or 6 languages. That we
Well,
all
that's
speak.
great. Oh, thank you. That's really helpful. So Huzaifa, you have a completely different kind of perch and a different population that you see. Can you sort of describe that?
Hi, thank you for having me here. I am a clinical assistant professor at USC. I work in the outpatient clinic at Keck Medicine of USC, so it's mostly outpatient, private insurance, so a different patient population. But I do also work at LA County ER for the psychiatry department, maybe not as frequently, but once a month. So I have like both perspectives, a different patient population in the outpatient clinic and also a different socioeconomic background when it comes to the LA County ER. Yeah.
Okay, great. Elyn, just please jump in whenever you want to. I was going to, go ahead.
Yeah. So, ask a question kind of
If
thing?
you would like.
Yeah. So I just wonder what everybody thinks the kind of treatment of choice is for someone, for two groups. People who have post-COVID psychosis and delirium, which Pam so brilliantly sketched out. And then also people who had a pre-existing mental health condition, but whose condition was exacerbated by the pandemic. What do you think the best way to approach this population and treat this population would be? Or some of the best ways, there may not be one.
I'll go ahead and get started. Well, what I've found is that it's necessary if I detect that there's an onset of psychosis, delirium, dementia, what it may be, for someone that may have not had those type of symptoms previously, then certainly refer them out for a neurological evaluation or a neuropsychological evaluation. One of the frustrations I have working in a small town in Mississippi is we have one neuropsychologist, a buddy of mine, Dr. Rod Wilson, and he's moving to Chattanooga next week. So, y'all have been talking about, resources and barriers to care and things like that. And so certainly in rural America and rural Mississippi, it can be very difficult. So I would certainly want to get them evaluated and then perhaps do a rule-out diagnostic assessment, perhaps some testing in some way, shape, or form. But as far as working with them psychotherapeutically, I think the main thing would be just to continue what you're doing and then ramp up whatever might need to be done from a CBT perspective or any support they may need. If there's some type of denigration in functioning with their activities of daily living, certainly want to integrate the resources, the existing resources. And I'm finding I'm doing more family counseling now, particularly for people that do have an exacerbation of mental health conditions due to COVID. And I also want to make sure I mention the shadow pandemics that I seem to have been experiencing in the last couple of years. So it's not just the primary COVID conditions, but the domestic violence. the increased, the onset or the exacerbation and the relapse rates of people with substance use disorders. And then, of course, a lot of grief work. So we've talked a little bit about people that have been in recovery from COVID, but I deal with a lot of people whose loved ones have died from COVID. And so I'm doing a lot of grief work these days. So I think the main thing is just, staying the course. And I think Dr. Eli talked about being there with them and stepping up to the plate, like, again, what Turin was talking about. Things we've already been doing. But this has been a big deal for us. This is a once-in-a-lifetime event. I've always said, I hate that it kind of happened in our lifetime. I don't want it to happen to anybody else, not wishing any ill will on any other populations or eras in our history, because it's just a big deal. And so we're just needing to stay the course, but also step up to the plate.
So the same question. So definitely I would, I've not treated someone with post-COVID psychosis, but what I've read, this is something that would definitely treat with antipsychotic medications, that I would treat it with like I would treat any other psychosis, but I agree, a neurological evaluation, neuropsych evaluation is needed. But I think there's so many things about COVID and how it affects the brain and psychological processes. There's still so much that we are learning. And I think we have to continue to follow the mental health trends for years and see, how it affects the brain, how it affects people with underlying psychiatric illness, or how it impacted people with no underlying psychiatric illness. This is something we have to follow for years, and more research needs to be done in this aspect.
Yeah, I agree with everything so far, but I would also add the peer perspective. So Pain and Brain's mission is to create lasting community-based solutions to mental health challenges and the impacts of social injustice through arts, advocacy, and enterprise. And we've recently added harnessing technology for social good. So we really believe in a peer response. And I think some earlier panels talked about support groups and having spaces where people can meet. That's also similar kind of peer work, So we do really believe in support groups. We have groups online, and the response for someone with those specific situations of either delirium or psychosis. Again, we believe in the community, right? Like bringing them back into the community, letting them know they're not alone, having a space for them to be in. We're not, we don't prescribe medicine, we can't do the tests you all talked about at Pain and Brain, but we can provide that community-based solution and that space to belong and the understanding that people aren't alone.
Thank you. Those are all really insightful. I'm interested in maybe having each of you address how you think the pandemic has affected mental health for both people who were already receiving treatment and already had diagnoses, and for people who didn't. What are you seeing there in terms of everything from, the kind of care they need, what you think is causing whatever changes you're seeing, just whatever insights you can provide on that. Yeah. Do you want to start us?
Sure. I think, COVID affected mental health in so many different ways. For people who had a mental illness, not having access in the beginning, as a lot of community health centers closed. I know a lot of inpatient psychiatric hospitals, they didn't have the support, so they basically closed down. A lot of ER visits, as I was working in LA County ER in the beginning, in the middle of the pandemic, we did see a lot of surge. One of the speakers said before, people with suicide rates increased, substance use. A lot of people were using alcohol and other substances to cope with social isolation, grief, loss of their loved ones. So we did see that spike in the ERs. And not having support, not having medications, that did increase, of course, for people who had an underlying mental health illness. Of course, they did have a relapse because they didn't have access to treatment. In the outpatient clinics, again, there was surge. Definitely, we have been so busy. So that was in the beginning of the pandemic in terms of ER visits. But I think people who had no underlying mental illness, definitely I have seen in the outpatient a lot of fear, which could lead to anxiety, depression, the social isolation, self-quarantine from family members. That did increase the rates of anxiety disorders, depression. I have seen a lot of burnout among parents who were holding a full-time job and caring for their kids at home. A lot of burnout that was causing anxiety. And I remember like having these conversations with a lot of parents who were my patients, and usually I don't share stories, but as a parent myself, I could validate and relate to stories. And I know therapeutically it was helpful for them to hear me saying that I can understand what you're going through because I have kids at home screaming and running around when I'm taking care of patients, and I validated their concerns. So definitely people who had no underlying mental health illness, we did see increase in anxiety disorders, depression. And I think, for me, I feel like, my worry is we have to follow this trend. As we have, if we extrapolate the data that we have post, hurricanes or 9/11, we did see increased trends of depression, PTSD, trauma for years. And I worry that, if we don't improve the mental health services, this is going to continue. A mental health crisis is coming.
Tristan?
Okay, yeah. Again, I would come back with community and peer support, which is what Pain and Brain does. In terms of our community center did close down for a certain number of months during the pandemic because it was just, we had to, because we didn't have it was required of us to close for a while, I'd say. And a lot of people did suffer, there was regular people who came to our community center. As soon as we reopened there was this core group of people that came back and said, this place really needs to be open, for mental health, right? Not necessarily in a hospital or in a clinic or something, but just a place to belong, a place to be open about. In terms of I will say the pandemic has been good in some ways, I think, for mental health, because so many more people are talking about what mental illness is. So many more people have experienced isolation. So many more people have experienced anxiety. So many more people, and suicidal rates. I don't know what the proper rate is or if it's gone up and down, but I know that a lot more people are talking about it now. So I would say the one good thing about the pandemic is that it's getting people to talk about things that, in our community has been around for a long time, but no one, for whatever reason, they're just not, mental health is coming front and center in a lot of ways. So that's what I'm saying.
That's really interesting. Lynn, do you want to?
Yeah, I agree. I know in 2020 when it kind of came about, I think that society had a similar perspective of what was going on as clinicians and physicians did, and the doctor was talking about how they just didn't know. Well, we just didn't know. Well, neither did society. I think they were trying to sift through and try to figure out, okay, what's going on here? What are we to believe? What are we going to do? Well, with our facility, ultimately in April of 2020, I was able to take a month off because the state of Mississippi shut down. But then shortly thereafter, the leadership team at our organization said, we have got to stay connected to these folks. So we came back in. I worked with about 30 other psychologists and therapists, and we got on the telephone. And as far as something good that came from this horrible tragedy that is COVID, is telemental health. We actually lost a lot of therapists due to having to shut the doors and things like that, but I went and got the board certification for a telemental health therapist, kind of anticipating, hey, I might not have a job when I come back in May. But either way, so we got on the telephone and we stayed connected with these folks. And what we found was there's a significant number of people that really like that. And even though we have not transitioned to full video conferencing, you can imagine, the internet service in rural Mississippi is not that great. And then, of course, hardware, and so connectivity issues are a problem. But I'm hoping that that's something we're going to do. Was there an exacerbation of mental health conditions? Absolutely. I would say about a 40 to 50% increase for pre-existing people with psychopathological disorders. And I'm also seeing a lot of my older clients that I haven't talked to in years and years that are calling me back in the last year or so. So, hey, I need to come back in. This is what's going on. Certainly, I followed this kind of cyclical thing that happens socially where, let's say, when the economy gets bad, there's higher incidence and presentations of mental health people coming in. But certainly with this, I'm seeing a lot of people coming back in. So I think there's been certainly an increase of the new novel onset of mental health conditions, and certainly an exacerbation of existing conditions. And then, of course, you have substance use disorder. There was things in the newspaper in Meridian last year talking about they've had the highest liquor sales in the state's history in that town. So
Yeah,
what are they doing? Well, they weren't working, so they're at home, and then they're drinking, and then their domestic violence goes up, and so.
Yeah, I want to
Certainly.
underscore both of these comments, which
Sure.
is that there has been an upside of COVID, kind of a silver lining, which is more people understand depression and anxiety and fear and are probably better able to empathize with people who experience those things because of their mental health condition. And also in terms of video care, a lot of people said, can't do it over the internet, it's just not possible. Well, it turns out it is possible, and it's maybe not quite as good, but it's pretty damn good, and that opens up access to people who are geographically remote or don't drive or whatever. So kind of a silver lining a little bit.
Right, and I think when we were talking earlier, I think it was, Huzaifa, you were saying that actually, in some ways, telemedicine can be helpful to both the person with mental health issues and the therapist, because as a therapist, you can actually see them in their own environment, right?
Yes.
Do you want to expand on that?
Sure, yes. I think it was for me. I don't do psychotherapy. My job is mostly prescribing medications, but COVID did change a lot in terms of providing care. Seeing patients in my office versus in their comfort zones, it did open up a lot of conversations. I think I have had so many great conversations with my patients during this time when I was video conferencing with them. Just like, when they were sitting with their pets, having a conversation about that, or a piece of art hanging behind and having, to talk about what they like to do outside of work or something. It did open up a lot of conversations, and generally I think that patients were more comfortable. It did improve access. So I do that does, again, I agree with access. It did improve a lot of access. But I also think, particularly vulnerable patient population, elderlies who didn't have access or who didn't know how to use this modern technology, I feel like for them it was hard, and we need to do something about improving access. Or people, who don't have smartphones. There are a lot of patient population, like I said, like with the ERs, the work I do with LA County ER, I know the patient population there, they don't have smartphones, they don't have internet. So I think it did improve access. That's one side of it. But the other side, we need to, it did point out the social and economic healthcare disparities. So there's a lot of work that needs to be done. The pandemic did have a good side, if you think about telemedicine, but then there's another side. It highlighted that disparity, and we need to work on that.
I was going to say, it kept them safe also. It kept, during this, as far as infection, it kept me safe. With my borderline hypochondriasis. Is there a therapist in the house?
I would agree too, and I see it from both sides in some ways, because I'm a person with schizophrenia, and I did get telemedicine, right? Like my psychiatrist, at first it was on the telephone, and then later it was on video when everyone figured out how to do it, And even now, even recently, I'm still seeing my psychiatrist through video. And then from the pain and brain side, we moved a lot of our services online, so people could join groups online. People could have interactions with people online. We have an 8x8 number, so people could call in like you were saying, some people don't have smartphones. So we said, okay, we need a phone number too, like old school, right? In case someone calls in. So those are the kind of things that the Pain and Brain did.
Yeah, really interesting. Elyn, did you?
No more
No.
to that.
I'm just sort of along these lines. I'm interested in fixes that you guys would, what would you do to fix the holes that you see? I mean, obviously, supply of trained professionals is a big deal that you were mentioning, Lynn. I don't know how we get more people interested in that, but are there other things that you would suggest as ways to fix the problem?
I teach part-time at Mississippi State University. I teach psychology courses to bachelor's level and sometimes master's level. And I'm constantly encouraging them to get their master's and perhaps go on to get their doctorate. And I think having existing facilities facilitate or go into the schools and say, hey, we can provide an internship for you or something of that nature. We can't keep enough therapists. I mean, we are understaffed and overworked. And so that's certainly one idea, just trying to get people interested in the industry and know that it's needed. And of course, maintain parity, which is important for reimbursement.
I have done some work on, quote, high-functioning schizophrenia with a psychiatrist at UCLA, Steve Martyr. We define high-functioning as professional, managerial, technical, full-time student, full-time teacher. And I asked Steve one day, what percentage of people were high-functioning in these senses? He says, I don't know, Elyn. The real question is how many could be if we devoted proper resources. And I think that's exactly right. We really just need to step up to the plate and give people the care that they need so that they can, live up to their potential, basically, and have a good and happy and productive life. And I think that's possible.
Yeah, I agree with that.
We can't always guarantee what level of functioning
Right.
someone may have with our services, but we can pretty much guarantee in the absence of those services what
Absolutely.
we can expect.
Absolutely.
Do you want me to, can you tell me the question one more time? Or I'm still.
Oh, I was just wondering what you would, how you would fix the holes in the system, the problems in the system.
Yeah.
Well,
I mean, I guess from the pain and brain perspective, and I think this is very true, that peer support is something that's really taking off right now, and pain and brain's a part of it. But like SB 803, there's a lot of talk about. I think too, future plans, making future plans. There's a lot of talk about psychiatric advance directives, which Dr. Sachs has done a lot of work with too, and I think those kinds of things can be very useful too, and peer support. Support groups of different kinds can sometimes augment some of the shortfalls in terms of staffing of other mental health professionals. And we at Pain and Brain really believe that peers can be a really important part of this.
I think we definitely need more resources. And that's so many things. When I say resources, it's inpatient hospitals, we need IOPs, we need partial hospitalizations, we need more outpatient clinics. When I was working in LA County ER as an ER psychiatrist during the pandemic, we had a hard time. And as I was listening to the earlier lecture with the frontline workers, I can relate that so much to that, because when we had people waiting to get admitted in the psych hospitals and we didn't have places to send them, they would be in the ERs for 3 to 4 days. And I can't tell you how frustrating that was as a psychiatrist. I would be at a shift seeing a patient, and then I would come to the next shift a week later seeing the same patient waiting in the ER and not having a place. It was frustrating. So we definitely need more inpatient facilities. At least I can talk about the LA County hospitals. We need more. Yes.
do any of you deal with children with mental health issues? Because that's getting a lot of attention right now. And, I think it's interesting. I mean, for some kids, being at home probably has been good. Not having the stress of school if they were having trouble navigating school, and maybe being more with their family. But for other kids, it's been really hard. And Surgeon General has declared a state of emergency in essence for kids and mental health. And I guess I'm just wondering if any of you have thoughts about what's going on with children and young people in connection with all the things that we've been talking about today.
I think there are a lot of really interesting issues. So if you have a child, say under the age of 16, and mom and dad think they really need care, they don't really have a say in whether that happens. The parents get to make the decision, provided that the mental health professionals underscore that something is going on. But then when someone's like 16 or something like that, there's an argument that we should empower them to make their own decisions because they're becoming adults. They know themselves best and maybe care about themselves most, and maybe we should really, foster that kind of autonomous decision making. And it turns out, that most jurisdictions, the age of adulthood is like 18, but the age of adulthood for purposes of checking yourself into a hospital is more like 16. That's not true everywhere, but it's true in some places. But it's kind of an interesting and important, right? Because if you are able to address the mental health challenges when the person is young, they're likelier not to, quote, tip over into psychosis when they reach that age where that happens.
I mean, anytime we can deal with autonomy and choice, I think is super important, and I would like to empower that as much as possible. I don't think Pain and Brain mostly works with adults, but we do have OTs, occupational therapists, and social workers, and we do work with children and families also. And I think again, I think choice, autonomy, as much empowerment as possible.
So I don't work with kids. I'm an adult psychiatrist, but having kids of my own, I have seen how much it has affected. Just to give you a personal story, my son, when this started, my husband is also a frontline worker, and he was working this whole time in the pandemic, and he would hear us talking about the COVID, and it affected him in a way that he would wash his hands so many times. It got to a point where I could feel that his skin is so dry. And he heard me and my husband talking about, you have to count 20, and he would literally count till 20 multiple times a day. And he got over it in a few months, but I can see that how it affected him emotionally, mom and dad talking about COVID and dad being a frontline worker and not having that outlet, the structure that he was getting in school, not having those social connections. It was hard. I can attest that as a parent, not working with kids, but I can see how it has impacted our kids, and the Surgeon General declaring the crisis. Yes, yeah.
Lynn, do you want to talk about that at all?
Well, I work with adults, but also teenagers too. I mean, that question about kids and COVID is almost like, hey, let's talk about abortion and things like that, because do we keep them in school? And what about the mask mandate? And what about not being in school? And of course, we know it's vitally important for children to be in school for socialization, and of course, the educational continuity factor. And so that's been a big issue in the state of Mississippi, with whether the governor is going to, enforce the mask mandate for kids and when they're going back and all that. So that's certainly something we could talk about all afternoon about. I feel that there has been an increase in problems with children since COVID, and I have spoken and counseled with parents about how to deal with their children about COVID, and I've just encouraged them to sit and let them talk. It's kind of like the oyster, wait for it to open and don't force it on them, but try to answer questions, try not to alarm them depending on their age range and development. And of course, we have a children and youth facility in our area that we refer to.
Really interesting. I wonder if any of you have questions for each other. If you want to talk shop or.
When can I come work with you?
I'd love you to come right away, starting after this event.
I got to go fill out an application. I'll be right back.
Thank you. What do you think the hardest about being a mental health professional at this time is for a provider? Asking.
Oh, anyone can answer that? Okay, so I'll go ahead and start. I think I guess the isolation, the barriers, that people are facing, the lack of places that are open, the lack of resources. Everyone seems to be talking about mental health, but like there's still the funding, the programs. It's not really here yet, you know. Like and even LA, I don't know what the number is. We have 60, 70,000 people who are unhoused, living on the street. So there's so many issues that I'm like, what's really happening? You know, like we're talking about it, but I think that the main difficulty I see is that where do people go? Like where are we going to send them? Like people see, send them to a program or something, but those, as far as I know, you know, those hospital beds, those programs, those places, they're not here yet. So, I mean, I think that for me, that's like, and like Pain and Brain reopened our community center. It's partially reopened. So like, I think there should be a Pain and Brain community center in every corner, right? Like we have 12 million people in Los Angeles County. We have one Pain and Brain community center. You know, it's like, I don't know. It's like, I mean, I think we need to talk eventually about some of those, what do you call it? Like inequities.
Well, you know, sure. What do you want to say about that? Because that's.
I think I mean, you know, I do believe in peer support. I do believe in choice. I don't think we believe in, you know, I just think there needs to be a lot more resources, a lot more places for people to go. And community, like, is really important to Pain and Brain too. Like having a space where people can belong. You know, a lot of mental health centers, like Pain and Brain doesn't do this, but a lot of mental health centers, to get in, you have to sign like this many pages of, you know, it's like, I had a friend, you know, who I knew when I was in the state hospital. He got out of the state hospital. I got out of the state hospital. I was in a court-appointed program. He got released before me, so he got released out of the program before me. And you know, he stopped taking his meds, and he started decompensating. And a friend called me and said, "Hey, you know, go visit this person. You know, help them." So I said, "Hey, let's go down to the clinic. Let's get you signed back up." So I drove him over there. We went in there, and it was a thing, a stack of paper. And he looked at the first one. He signed one, and it was like, "No, I can't do this." And those kind of barriers where like people like are just excluded because, you know, of the bureaucratic problem. And I think we need more direct care, more like you know, like what you were talking about in terms of like actual, you know, spaces, and I think that could be a really big change. And I think for me that's the main problem I have, is there's not enough resources, places, community centers, places for people to go.
I mean, since I've been here, two of the main psych hospitals have closed, namely St. John's and Cedars, over the last 10, 15 years. And we just don't have the beds. I mean, personally, I think we should try to do as much outpatient work as we can, and that
Exactly.
hospital should be a last choice, but it should be available if it's needed.
I have a personal experience with this, not having enough resources and feeling frustrated as a provider. So when the pandemic started, we were not taking new patients at USC because we technically were full, but we needed to see new patients. So we came up with a policy that we are going to stabilize patients in 3 to 6 months, which is not always possible, and send them to primary care doctors for refilling their medications. Just to give you a background, sometimes it works for someone who has an anxiety disorder or a panic disorder where a primary care doctor just refills every few months, but that's not possible for all patients, and a primary care doctor is not well equipped. You know, we love working with our primary care doctors and we collaborate, but not for every patient. It's not possible. It's outside their scope to do that. And we came up with that policy so that we can see new patients and send some of our follow-ups to our primary care docs. And it was just not possible. And it came to a point where I started like giving up that idea. And I was like, you know what? I am not going to send anyone out, no matter what. Like, we will have to accommodate, and we can't send these patients to primary care docs. And the other thing is that some of the patients need IOP, intensive outpatient program, or a partial hospitalization. They are at a point where they don't need to be hospitalized, but they can be managed in an outpatient clinic. We don't have enough spaces for them. We don't have places to send them. So that's, again, something that we need to address. Having more intensive outpatient programs, having more partial hospitalization programs. And particularly with COVID, it was hard. A lot of places that I know were closed, or they were doing only on something on Zoom, which is not helpful for a patient who needs more structure. So that was my frustration in the pandemic.
Yeah, Lynn.
I had a couple of things. you reminded me of. I did want to say one thing I noticed through this is that the patients that were staying close with their counseling and staying on their medications amazingly did better than I thought they would. Some patients I work with that have some profound serious mental illness tended to exhibit good resiliency through all this. I just wanted to mention that I've seen that, but when I thought about it, I thought, well, they're the ones that really are keeping up with their counseling sessions, they're taking their medications as prescribed and things like that. In reference to what we've all talked about, particularly the first responders, and I've worked with more first responders coming in for counseling now than I ever have. But for all of us that are on the front line that encounter primary and secondary mental health and or substance abuse patients, I think a prophylaxis effect is important as far as us not going through this vicarious traumatization, secondary traumatization, job burnout, which is very prevalent. And look at the healthcare workers that are leaving the industry. So we've got to integrate, we've got to step up our game to take care of ourselves. I know on the weekends, my wife and I, we try to get out of town. Kayaking is my therapy, you know, on the lake or doing yard work or something like that, but I've got to do that work-life balance and self-care. I think we should be going into hospitals and other organizations and doing work-life balance seminars and things like that strategically now, to be sure. So we have to address it on an ongoing basis, not just wait until it gets really bad and you know that you're burnt out. So that's really important. Self-care and doing our own work and getting your own therapist. So Zig Ziglar said the only way he was able to sell more pots and pans back in the 50s was to buy his own set, which he did, and he actually started selling more. You may have heard of Zig Ziglar. So we have to do our own work. As I have a therapist. So if I'm going to be a therapist, I need to have a therapist. And so I think we all need therapists, just like we need primary care docs.
I totally agree. Do we have time for one or two questions from the audience? Sure. Anybody have any questions?
I don't know. Are we going to take a question? What do you think?
There he is.
All
I have a
right.
lot, yes. But the main thing is, over the years, and maybe Charmille and the California Mental Health Commission that has some funding to put money into services and done a lot of great work, is like every year, every half year when we get together, we need more services. We need more programs. We need more, and we all agree on that. And I guess the question for this room is like how and when and how do we change that stigma that you might say that's at a legislative level, talking about them, those people, not us. We're all human, but I don't know the answer to that. But it's like how often are we gonna have to say we need more, and keep saying that next year, So I don't know if that's a question or not.
Is it a question?
We'll allow it.
Well, I like what you said, Chris. I think we do need more services. I think we need, I think, I don't know what it's going to take. I mean, if this pandemic doesn't do it, I don't know what's going to do it, because I think for the first time, a lot of people are talking about this, and a lot of people saying, hey, wait a minute, anxiety, depression, even hardcore things, like, suicidality or psychosis. I think all of these things are much more in the public discourse now. Whether we're going to be able to translate that to really turn the system upside down and make it change, I hope so. I think Pain Brain wants to work for that.
So actually, when I recruit students to be part of my Sachs Institute, I ask them to write an essay about why they might be interested. The first 10 years, about 75% self-disclose as having mental illness in themselves or a loved one. But when we met as a group, only one person self-disclosed, which is kind of stunning because law students are all about liberty and dignity and rights and that kind of thing. The most recent year, 85% self-disclosed out loud in the group, including one woman who said, I've never before said this outside my family. I have bipolar 1 with psychosis. It's anecdotal, it just may be chance, but maybe things are getting better in terms of stigma.
I want to point out to one good thing that happened at USC, because I don't want to report only the negative things and we need more. One thing that came out of the pandemic was we have a Care for Caregiver program. I don't know how many of you know, at USC we do have that for our faculty and employees that just came out in the pandemic for our frontline workers. And that's one thing that I'm so passionate about. I've seen so many frontline workers in the pandemic and hearing their stories, the trauma that they've experienced. And like one of our speakers was saying before, I'm sorry, I forgot your name. But we need more. We just don't need a lecture on burnout. We don't need a lecture on self-care. We don't need that. We need more resources for our frontline workers. And I'm sure we need to follow this trend, the trauma that you all have experienced with this pandemic. We need to follow that and see what else we can do for our frontline workers, for our employees. I think for all the faculty members who were coming and working throughout this pandemic. The fear, I've seen that, the fear, the anxiety, the fear of getting infected, the fear of getting their loved ones infected. So we need more for them. And I think, one thing that I said that before, that, one thing that came out of this pandemic, this Care for Caregiver program, we need more of that. Just not a lecture on burnout or self-care. That's not going to do it.
Is this working? Okay. So from what y'all have said, it really sounds like the past 2 years have highlighted the importance of the social component and the environmental component of mental illness. So if y'all don't mind, if you could just speak a little bit to how perhaps this is an opportunity to branch out from purely medical model and start putting resources into these social and environmental components that, as we've seen, even people without diagnosed mental illnesses have struggled. So I just like to hear y'all's thoughts on that. Thank you.
Thank you, Lori. Yeah, I agree. The recovery model, right? The recovery model, is that what you're talking about, Lori? Yeah, absolutely. So the recovery model believes that everyone can recover, which sometimes, I'm not totally versed on the medical model, but I think the medical model is more deficiency based, and the recovery model is more about like, how can we create that like supportive community, like what Elyn was talking about, that where people can actually flourish, recover, transform their lives. And, I'll say this too, some of the most interesting people I met in my entire life were people in the mental health system, and often in some of the most regressive environments. Like, I don't know who's here's been to a boarding care or been to the psychiatric part of the LA County Jail or been to the Patton State Hospital. These, but they're resource deserts, right? There's nothing to do there. There's nothing to do there. And really, the recovery model is like, wait a minute, if we give people the environment, if we give them the community and all of these things, I believe everyone will flourish if we do that. I think absolutely everyone can recover. And if we create those spaces, I think I think the medical model, it just stops right here. When you don't have symptoms anymore, that's it. But the recovery model is like, wait, what do you want to do with your life? How do you want to live? Like, you want to be an artist? You want to be a lawyer? You want to be a doctor? Like, let's have people completely reintegrate into the community, recover, and be the people they always wanted to be.
Yeah. Instead of focusing on reduction or remission of symptoms, focus on quality of life, which it's for the person with lived experience to decide what that is for them. So,
I'll never forget one of my is this on? Yeah. I'll never forget one of my professors saying, "Thou shalt not over pathologize." Of course, we live by the DSM, and then of course I'm trying to conceptualize not using the DSM and just realizing that some things are just people's normal behaviors trying to get their needs met. Yeah. If we're not planting seeds of hope, we're not doing our job. Yeah. We have got to make sure people know that there's hope and there's possibility for change, and the help is out there. Now, not much pathologically keeps me awake at night. What does is politics cutting funding. That's what gets to me. Another good thing that's happened, it seems like in the last few years, the government is providing more funding for, because of the opioid epidemic, and that's a whole other thing to be sure, where we're getting people into our treatment center at no charge, and so that's really good, and so that's helping there. So again, we got to plant seeds of hope. The day I quit doing that, I'll move out here and start selling Teslas or something. I don't know. Seems like they're everywhere out here.
I think that's Sounds like a good note to end on, or is there somebody else? Did you?
Yes, yes.
Oh, I'm sorry, go ahead.
Just curious, if there was an implementation of a peer support model here on the campus, how would you guys envision that looking like, or, functioning, if there was that recovery model implemented on the campus to really relieve mental health professionals, as one of the challenges you were facing, that there's a shortage of staff or support? How could that be implemented here? Thoughts?
That's a little complicated. I have so many ideas about that, but I don't know how that will be implemented. Just to give you a background, I have worked on this campus for 1 year with USC Students Health. And again, it was not easy because we don't have enough services for our students. And those of you know, we have a short-term treatment model at USC. When I started here, worked here 1 year, it was a short-term, which was, to me, fascinating. What do you mean by this short-term treatment model? It's basically, you see the students, give them medications, do short-term psychotherapy, and send them to community. And I was like, okay, what community are we talking about? Just send them to give them a bunch of referrals, which we did. And even that was not updated. A lot of places had closed down. They were not accepting new patients. They didn't know which insurance they could cover, which they couldn't. So it was like, I was frustrated as a provider, like, where do I send them? And it was so frustrating that I as a provider, was feeling a lot of anger for these students. Like, I am sending them just a message through an electronic medical system. These are the bunch of referrals. Go figure it out. And that was a lot of frustration that I had. Sending them to hospitals or an inpatient, an intensive outpatient program. Again, I struggled with that as a provider. There was a lot of frustration to the point where I almost questioned, what is my role here? And I don't want to be that kind of provider. Okay, this is your bunch of referrals, go figure it out. And that was a part of the reason that I moved to Keck Hospital too, because I was like, I can't be that provider where I will just hand out a bunch of referrals to you and tell you, I can't treat you because we have a short-term treatment model. So I don't know what would that look like. I'm sorry, I don't have an answer. It's so complicated. I hope we have more resources. And I don't know what that's going to look like. What would it take? And I hope that this pandemic has highlighted the challenges that we have also as providers. And I hope the patients do see that as providers, sometimes we don't know the answer. A lot of it is not in our hands. We want to help you, but we don't know how to help.
So I feel like USC is trying to do a good job in the space, the law school. So in our orientation meetings these days, which everybody comes to, I usually speak about breaking down my first year of law school on how stressful first year of law school is, and here are resources and here are things you can do. And then we have a mental health professional talk, and then we have an alum talk, sort of having a conversation about these kinds of things, which I think can be really helpful. We also talked about, and I'm not sure how much we're doing this, having a mental health professional on site at USC Law School 1 day a week for anyone, staff, faculty, students to approach. And then there are also kind of little things that the students do. So they put out a pen of puppies during the exam period for students to come out and pet the puppies and kind of de-stress. And I thought, what a great idea. But yeah, so we're trying to do things.
We do the same thing in Mississippi, but it's coyotes.
To brag about the law school, but we actually have 2 mental health professional psychologists, and they're here, one or the other, all week long, all day long.
Okay,
so
wow, every day.
Let's do
Wow.
more of that.
Wow, that's great.
All right. Is that a wrap? Should we, did anybody else?
Yeah, I can answer that too. Yeah, and thank you for the question, Eli. And I think there are ways. Painted Brain partnered with the Chan School of Occupational Therapy, and I think Eli helped helped create that program, the Expert by Experience program, which was really interesting and fascinating. I worked there as the Painted Brain, one of the Painted Brain staff who helped the professors teach about mental health. So there might be ways for other social work, or who knows, other agencies or programs to bring in peers more to talk directly rather than just as a panelist on one night, which I've done a ton of times, but actually bring them in to the school and sort of have them be part of the education, if you will. You know, that would be really good. And also having peers be more open and connected to students.
Well, really good ideas. Have I gotten the time signal? I'm getting the time signal from Chris. Okay. Elyn, I don't know if you want to say anything in closing, but I'd just like to say thank you all for being here again, and thanks to our wonderful panelists on this panel and all the other panels. It's been a privilege to be part of this event, and I've learned a lot, and hope you have too.
Yeah, I'd also like to conclude by thanking all the people who participated as speakers in this event. Your contributions were awesome. I also want to thank again the wonderful staff at USC from our events office who made this all possible. And again, the main guy, Chris, for his amazing work with me and the Sachs Institute. Thank you, Chris. Fight on, is that fight on? Okay. Yeah, thank you so much.